Ever feel like you just can't catch your breath? Like every inhale is a struggle.
Yeah,
It's a scary thought, right?
absolutely.
And for millions dealing with COPD, that's their daily reality.
It really is.
We're diving into some intense medical territory with these excerpts you sent us. COPD and asthma.pdf.
Lots to unpack there.
Really is. We want to help everyone understand how these diseases actually work. What happens in those critical moments when things get really bad?
Right. Those exacerbations, they can be terrifying.
Totally. And when it gets to the point of needing intensive care, what then? So many questions.
Absolutely. And those are the questions we're going to answer.
We've got COPD, we've got asthma, both messing with your breathing, but in different ways, right?
Absolutely. It's like picture your lungs as an accordion.
Okay, I like that.
With COPD, imagine some of those folds are stuck together. They can't open properly.
So you can't get a full breath.
Exactly. It's this irreversible airflow limitation. The damage is done, and it's happening in those tiny air sacs, the alveoli.
Right, I've heard of those.
Yeah.
They're like damage beyond repair with COPD.
Sadly, yes. Imagine like overinflating a balloon over and over. Eventually, it loses its shape, that ability to bounce back. That's kind of what's happening in those lungs with COPD.
So the damage is done, and then it becomes about managing what's left.
Exactly.
With asthma, though, that's where we see more of that, like, hair trigger reaction, right?
Exactly. Asthma is all about those airways being super sensitive, hyperresponsive. Allergens, irritants, even cold air can make those airways spasm, close right up.
It's like they're on high alert all the time.
Totally. And that reaction, the good news is it's often reversible, especially if we catch it early and get it under control.
Okay, that's good to know.
Mm-hmm.
But it must be scary,
Right.
never knowing what's going to set it off.
You're right. And this is where that whole time constant idea comes in from the text.
Oh, yeah, I saw that. What was it? Like how long it takes to empty your lungs?
Yes, it takes way longer in COPD. Think of letting air out of a balloon versus like a car tire.
Okay, I see. The balloon empties fast.
Exactly. COPD with those constricted airways, it's like that slow tire deflation. It just takes forever for the air to get out.
It can't keep up. So we're picturing restricted airways, air getting trapped.
Right. It's a recipe for trouble.
It all sounds pretty exhausting.
It is. It takes a toll on your body.
So when we talk about these conditions flaring up, those exacerbations, what's actually happening in the body at that point?
That's when things get really serious. And the text talks about dynamic hyperinflation, which I know sounds a little intimidating.
It kind of does, like your lungs are about to burst or something.
Well, maybe not quite that dramatic, but it does put a ton of strain on your whole respiratory system. Imagine trying to blow even more air into a balloon that's already super inflated.
Oh, man. Like it's going to pop.
It's that feeling of not being able to get a good breath in no matter how hard you try. Your lungs are already so full of air that's trapped there.
And I'm seeing these graphics in the text, figures 2 and 3, showing how this dynamic hyperinflation actually works. Thankfully, you don't need a medical degree to understand them.
And that's important because this isn't just about the lungs. Think of it like a domino effect. It triggers a whole cascade of problems. Look at figure 4, if you have the text handy. That strain on your respiratory muscles, it throws a wrench into everything. It impacts how well oxygen gets into your blood. It can even affect your heart.
Wow. So we're talking a whole body issue here. What usually triggers these exacerbations?
Infections, especially respiratory infections like colds or the flu, are a major culprit.
So important to protect yourself, especially during flu season.
Absolutely. And I thought this was really interesting. The text mentions this overlap syndrome with COPD and sleep apnea. For those listening who might have trouble sleeping, it turns out these two conditions can actually make each other worse.
Really?
Yeah. Something to definitely discuss with your doctor if you're concerned.
For sure. So we're dealing with some pretty heavy stuff here. We're talking about emergency room visits, right?
Sometimes, yeah.
When someone comes in struggling to breathe, how do doctors even know what to do first?
That's where we head next.
So last time we left off, someone is headed to the ER, can't breathe.
Yeah, it can get scary pretty quickly.
What are doctors looking for in those first few minutes, when someone comes in gasping for air?
It's all about triage, right? Figuring out how serious is this and how fast do we need to act.
Because every second counts in those situations.
Absolutely. Are they talking? Are they turning blue? Can we hear air moving in the lungs?
Right, those are all critical signs.
We're looking for any indication that their breathing is dangerously compromised.
And speaking of danger, the text mentions something called silent chest. It was highlighted in Table 6, and honestly, that phrase just sends chills down my spine.
Yeah, silent chest is bad news.
What's actually going on there? What makes it so serious?
It's a sign that the muscles you use to breathe, those respiratory muscles, are just spent. They're exhausted.
Because they just give up.
It's like running a marathon, pushing your body to the absolute limit, and your legs just, they can't go any further. It's like that, but with the muscles you need to breathe.
That's terrifying.
It's a very serious sign. It can be a precursor to respiratory arrest, meaning your breathing actually stops.
So, bottom line, if someone's having trouble breathing and their chest is eerily quiet, that's when you call 911 immediately.
Absolutely. No hesitation.
So let's say someone arrives at the ER, they're in respiratory distress, maybe they even had that silent chest warning sign. Once things stabilize a bit, how does treatment differ between COPD and asthma? I mean, they both involve airways, right?
Right, but the underlying problem is different. With asthma, it's like we need to hit the reset button on those airways.
Okay, how do we do that?
Medications, mainly. Inhaled beta agonists, corticosteroids. These drugs work fast to relax the muscles around the airways and bring down that inflammation.
Like calming those airways down, soothing them.
Exactly.
And that's not as straightforward with COPD, is it?
Unfortunately not. Remember those damaged air sacs we talked about, the alveoli?
Right, the ones that can't really be repaired.
Exactly. So while we still use those bronchodilators, those corticosteroids, to open up the airways as best we can, it's a much more involved process. We're managing infections, really paying close attention to fluid levels, making sure the heart is supported, and we're helping those weakened respiratory muscles because they're working overtime in COPD.
It's amazing how resilient the body is, even when it's struggling like that.
Yeah, it really is.
But sometimes that resilience needs a little extra help, right? That's when we start talking about the ICU.
Exactly. And that think box in the text where it says, if in doubt, ICU, it really resonated with me. It just emphasizes how quickly things can take a turn for the worse with these conditions.
So let's talk about the ICU. What kind of interventions happen there?
Well, one of the first things we consider is NIMV, which stands for non-invasive mechanical ventilation.
Okay, break that down for us. What is that?
It's kind of like a CPAP machine, if you've ever heard of those.
Yeah, for sleep apnea.
Exactly. It helps push air into the lungs, but without having to actually put someone on a ventilator, which involves a breathing tube and everything.
So less invasive.
Much less invasive. And that means fewer risks, faster recovery time. Though sometimes a ventilator is unavoidable, and when that happens, it gets a lot more complicated.
Because then you're breathing for the patient.
In a way, yes, but we want to get them off that ventilator as soon as possible.
So let's say someone does end up on a ventilator. What are the goals in that situation?
Well, the text lists a few different reasons why someone might need mechanical ventilation. It could be to relieve that really intense feeling of breathlessness, what we call dyspnea.
That must be awful.
It's incredibly distressing, both for the patient and their loved ones.
So the ventilator helps with that.
Exactly. It can also improve how well oxygen is getting into the blood. And sometimes it's just about giving those respiratory muscles a break, a chance to rest and recover.
They're getting a much-needed vacation.
Uh-huh, exactly.
So how do doctors even measure how well the lungs are working when someone's hooked up to a ventilator?
It's tricky. The text even points this out. It mentions that trying to figure out the expiratory resistance, basically, how much resistance there is when you breathe out, it's really hard to do accurately in these cases.
Okay.
Think of it like trying to measure the flow of a river, but the current is constantly changing, and there are all these hidden obstacles under the surface. Conditions like COPD and asthma, they make that expiratory airflow really unpredictable.
So it's not as simple as just looking at a number on a machine.
Right. Doctors have to use their expertise, their experience, and they have to pay really close attention to all those subtle cues the patient is giving them to make the right call.
It's like detective work.
It really is.
So the text also mentioned different ventilation modes. What are those all about?
Oh, yeah, that's important. There are a bunch of different modes, and each one has a specific purpose. It's like fine-tuning the type of support your lungs are getting.
So it's tailored to the patient.
Exactly. And one thing that really struck me was how the text emphasizes getting people onto those assisted modes as quickly as possible.
What's the difference?
With assisted modes, the ventilator is still helping out, but the patient is doing some of the work of breathing on their own.
Oh, so it's like physical therapy for their lungs.
Exactly. We want to keep those lungs active.
Makes sense. And then there was this whole discussion about PEEP.
Ah, yes, PEEP. Positive end expiratory pressure. It's a mouthful.
It is. What is it, and why is it controversial in these cases?
So imagine this. PEEP is basically a little extra pressure from the ventilator that helps keep the lungs from collapsing completely after each breath.
So it keeps those tiny air sacs open.
Exactly. And for some conditions, that's great. But for COPD and asthma, it's a tough call.
How so?
Too much PEEP, and we risk making that air trapping even worse. It's like trying to blow even more air into a balloon that's already at the point of bursting.
Oh, I see. You don't want to push it too far.
Exactly. But on the other hand, a little bit of PEEP can be helpful to open up those collapsed air sacs to improve oxygen levels. It's about finding that sweet spot, that delicate balance.
It sounds like so much of ICU care is about that, finding that perfect balance.
You're absolutely right. It's constant monitoring, adjustments, making sure we're meeting the needs of that specific patient at that specific moment.
Because everyone's different.
Everyone is.
We've talked a lot about breathing, obviously, but the text also mentions some interesting differences in nutritional needs between people with asthma and people with COPD. I hadn't even considered that before.
It's something most people don't realize. With asthma, for the most part, your nutritional needs stay fairly normal, even during a flare-up.
Okay.
But with severe COPD, it's a whole different ballgame.
Really? What's going on there?
Well, COPD often goes hand in hand with this thing called pulmonary cachexia.
I don't think I've heard of that.
It's basically a fancy way of saying it causes weight loss, muscle wasting, even changes in your metabolism.
Wow, so your body's just not processing energy properly.
Exactly. So getting those patients the right nutrition, enough calories, enough protein, it's absolutely crucial for their recovery.
That makes sense. It's like giving your body the building blocks it needs to heal.
Exactly.
The text also mentioned something else I found really surprising. It said that chest x-rays, which seem like such a standard tool, they can actually be misleading when it comes to fluid overload in these patients.
It's true. You would think an X-ray would clearly show fluid in the lungs, right?
Yeah, it seems pretty straightforward.
But in COPD, that hyperinflation we talked about, it can actually mask the fluid on an X-ray.
So it's hidden.
In a way, yes. So doctors have to rely on other clues, other tests to get the full picture.
Like looking for other symptoms.
Exactly.
Wow, so much for a simple x-ray.
Right. It's not always as cut and dry as we'd like it to be.
And speaking of things that are tricky, what about managing fluids in these patients?
Oh, that's like walking a tightrope. Too much fluid, and you risk overloading the heart, especially in older patients or anyone who already has a heart condition.
Right, their heart is already working harder.
Exactly. But too little fluid, and you run the risk of dehydration. So again, it's about finding that sweet spot.
That delicate balance. We're seeing a theme here.
Haha, definitely. But that's medicine for you. It's complex.
It is. But it's also amazing what doctors and nurses can do, especially in those critical care settings.
Absolutely. They're incredible.
So we've journeyed through the ins and outs of COPD and asthma, explored the challenges of managing these conditions in the ICU. But what happens next?
The big question, right? What does life look like for these patients once they leave the hospital?
So we've really been through it with COPD and asthma, haven't we? Even explored the world of the ICU, what goes on in there.
Intense stuff.
But what's next, right? The immediate crisis is over, someone's headed home. What does recovery look like for these patients?
That's the million-dollar question, right? And unfortunately, like with a lot of things in medicine, there's not one answer that fits everybody.
Of course, every patient is different.
Exactly. But that medical text you shared, it does give us some clues about what the long-term outlook might be.
And it doesn't really sugarcoat things, does it?
Mm-hmm.
Like, it's pretty straightforward about the fact that for people with COPD, especially those who needed mechanical ventilation, the statistics, well, they can be kind of scary.
Yeah, there's no getting around that. The text points out that the mortality rate in the years after needing mechanical ventilation for COPD, it's high.
It is. And that's a tough reality to face.
It is, and it really highlights something we don't always talk about but should, those important conversations with your loved ones about your wishes for long-term care, what you would want if things got really serious.
Why? Because it's not just about extending life, it's about quality of life, too.
Exactly, and those conversations, they're never easy.
No, they're not. But the text really encourages people to have them, especially as COPD progresses. There's that think box about end-stage COPD that really made me stop and think.
Me too. It's something we all need to be more aware of.
Absolutely. But on a slightly more hopeful note, the text did say that a lot of people with asthma have a good prognosis, especially if they're managing it properly.
Right, and that's such a key point. Early diagnosis, getting on the right treatment plan, especially those inhaled corticosteroids, and knowing your triggers, it can make a world of difference. You can protect your lungs, live a full life.
It really comes down to understanding your own lung health, doesn't it?
It does. Knowing your family history, whether you smoke, have you been exposed to things like dust or fumes at work, and recognizing those early warning signs, it gives you the power to take control.
Knowledge is power, right? The more you know about these conditions, the better you can advocate for yourself or for someone you love.
100%.
Wow. We've covered a lot of ground, haven't we? From how breathing actually works to those high-stakes situations in the ICU, and then what life looks like after for those living with COPD and asthma.
It's been quite the journey. And it really strikes me how much we're still learning about these conditions. There's always something new to discover, new treatments being studied.
Speaking of new treatments, remember that mention of heliox in the text?
Oh, yeah, that helium-oxygen mix, right? It's like space-age medicine.
It does sound kind of sci-fi, doesn't it? But if it holds promise, why isn't it being used more often?
It's a great question, and it's complicated. We're talking about logistics, cost, even just getting everyone in the medical community on board with a totally different approach. It's not always easy, even when something looks promising on paper.
That's true. It makes you think about all the factors involved in getting a new treatment from, like the idea stage to actually being available to patients. It's a whole process.
It is. But hey, maybe that's a topic for another deep dive.
Definitely adding that to the list. For now, though, I think we've given everyone a lot to think about.
We have. And if anyone out there is concerned about their lung health, please don't wait. Talk to your doctor. It's always better to be safe than sorry.
Could agree more. Until next time, everyone, stay curious.